Thank you for having me. It feels, I'm very honored to be in a room with such incredible thought leaders in this space. And as many of you, I'm a member of ASCO, a volunteer at ASCO, and it's a pleasure to give you an update on behalf of ASCO. However, I do not speak for them. I also don't speak for my university, so a lot of my thoughts are my thoughts. Here are some disclosures as well. And I'll start by going back to 2020 to explain the ASCO ACCC initiative, and then move on to the initiative resources that have been made available to our community, and then let you know where we're headed next, where ASCO is headed next. So with that, you may know about this initiative. In 2020, Lori Pierce was the president of ASCO, and Randall Oyer was the president of ACCC. And they decided to come together as both organizations to tackle the problem of underrepresentation in clinical trials. And they created this initiative to increase the racial and ethnic representation in clinical trials. And it was, the goal was to ensure that clinical trials reflected the diversity of patients with cancer, and to develop and test practical strategies and solutions to improve that representation. There were some key collaborators that were formed that you see here, and I'll speak about the first one, the second one, which is the patient partners, in 1 second. But as they came together, they decided that they wanted to engage the entire community and put out a request for applications. And in this RFA, they asked for ideas of how to move the field forward. I responded to that RFA and suggested that we propose a research site self-assessment to look at what best practices research sites were following and not following. And among those that they were not following, to educate our community about how they could improve their practice. Nadine Barrett was the other winning submission of this RFA, and she proposed to create the first unconscious bias training for oncologists. And so the two of us were chosen to lead this steering committee and work with the patient advisors. And then we split up the group into those two pathways, and then we'll show you what we came up with. So first, here are the patient partners who were just a critical piece of our work. They were chaired by Sanford James and Leila Hamroun, but you can see the many other individuals that were participants here, and they were involved throughout the entire spectrum of activities that we were involved with before the evaluation phase, during the evaluation, and post-evaluation, and then in the dissemination. I work closely with Mel Mann, and we're often speakers together speaking about some of these initiative products that we were all working on, and here they are. So the resources that came out from this group initiative were threefold, the first three, and the future directions are number 4 and 5 that I'll get into in the second half of my time here. So the first was that we created a joint statement from ACCC and ASCO to point out the 6 recommendations that both organizations felt were critical in increasing racial and ethnic diversity in clinical trials. The second one was the Just Ask implicit bias training that Nadine Barrett proposed. And the third was the research site self-assessment that I had proposed. And then we'll look at, going forward, the newly formed ASCO collaborative that for the first time this month. And then I'll talk a little bit at the end about some new recommendations that will be introduced by ASCO shortly. So the first one is the joint statement, which was published here, as you see, in JCO. And this joint statement addressed 6 critical pieces of research that has shown to increase clinical trial representation. So the first one has to do with access to clinical trials, and by that it entails some of the things you've already spoken about, which is that it's critical for a patient to be aware of trials and for doctors to recommend trials as part of excellence in care. The second one we've already also spoken about, which is the equity-focused design. By that, Karen Wingfield spoke about the trial portfolio as well as eligibility criteria and how critical it is that those be updated and modernized to reflect the diversity of participants that we want to engage in trials. The third is building long-lasting partnerships with community members who should have a say, who should have a voice in the design of these trials and all the processes that follow forward. And then education and training that should be focused both on implicit bias training, but also building of trust. How do you teach people to build trust with communities and patients? And then the investment in equity, diversity, and inclusion structure that one needs to be able to increase representation. And lastly, as many of you know, the data on inclusion and diversity in trials is actually suboptimal. If you look across all the trials being conducted, oftentimes these variables of race and ethnicity and socioeconomics and so forth are not even being collected, and if they're collected, suboptimally reported. So those were the recommendations. One of the things we talked about initially as a group, as a steering committee, was how important the recommendation by the physician or the clinician is, as we've already spoke about. You ask people why they participated, their number one reason is because their clinician asked them to. If you ask people why they didn't, it's the opposite. It's that they weren't asked to participate. There's a study among Black patients with metastatic cancer that should be offered a trial that showed that only 40% of patients had actually had a trial discussed with them. So the rates are really suboptimal, and there's a very limited data what is in that black box. What is happening during that conversation between clinicians and their patients? And that's something that I personally have become very interested in and have a grant to actually record and review. I want to look at what are those key ingredients in that conversation that actually lead to the patient participating in clinical trials. But more on that at a future meeting. So one of the things we found was that unconscious bias is real, not only through our research with ASCO, but that it takes on a very subtle form. And the best paper that I can share with you is this Naranjan paper that if you haven't read, it's really eye-opening. And what she did was she conducted 91 interviews across 5 US cancer centers, stakeholders, cancer center leaders, PIs, referring clinicians, and research staff. And 5 themes emerged. The first was that recruitment of minorities in clinical trials is suboptimal, and in part it's because they are perceived to be more challenged. And that's a lot to unpack there, but when you read the quotes, what I gather people were trying to mean is that they see patients who are underrepresented minorities as having less knowledge, sometimes having language barriers, and that's just more challenging. This person said it's just too darn hard to try to talk to them into a clinical trial, so let's just do standard of care. So it's much easier not to bring up clinical trials. And then language clearly was a barrier to the point where in a busy clinic, I wasn't going to take time to go get a translator and then spend an additional 30 minutes. The second theme was that the underrepresented minority patients were not seen as ideal study candidates. And when you dig into this, what they often meant was that they were perceived as having poor protocol adherence. So this person said, well, he lives alone. How are we going to make sure he does all this? I don't think it's worth asking him to take all of this on. It'll be too much for him. So again, assumption, which then subsequently lead to reduced opportunities for the patients to enroll in trials. And then the perception that underrepresented minorities were less altruistic than white patients was particularly surprising. This person said, I see that degree of altruism more in Caucasian women than I do in African American women. And then finally, they were perceived to have lower interest and higher degrees of mistrust, and they rationalized that this was because of the legacy of mistreatment in research, and so if they were perceived to have lower interest, they weren't asked. And so the problem is that there's real data out there by Joe Unger, who I think is at the meeting today, that refutes all of that. And he published a study when offered to participate that shows that among all patients, if you just ask, about 55% of the patients will agree to participate in a study, in a clinical trial. And he saw this rate did not differ significantly across all the racial groups. So this notion that certain groups are less altruistic or less interested is just false. It's wrong. It's refuted by the data. So that led us to really focus on the implicit bias training module that Nadine Barrett had proposed and how to adapt it. She had proposed it for the CTSA at Duke. And so ASCO began to work with this committee, the patient representatives, and physicians that participated. All across both of these projects, we had 75 sites across the country participate in these pilot studies. And you can see 40 participated in both the development of the implicit bias tool as well as the research site self-assessment, and then 25 in the site assessment only, and then another 10 in the bias training. And so I'll show you some of the data on the implicit bias training, but first I'll describe it. So Just Ask is a curriculum that spans about 5 interactive modules that you can complete in 60 to 90 minutes. And we also developed a facilitator's guide because we strongly believed in the committee that bias is something that, yes, it's felt at an individual level, but you have to acknowledge it, learn, and then bring back that information to change the structures so that you don't continue the biased behavior. If you just tell yourself, I'm going to stop being biased, that's not going to work because, as we already said earlier, all humans are biased. If you're human, you're biased, and it's really difficult to root out those biases. And so what you have to do is change the structures around you, change the system. So by creating this facilitator's guide, the bias training is meant to bring back the learnings and talk as a group together about what are the structural things that you can do to eliminate bias. And here's a screenshot of the training for Just Ask. That's my colleague, Nadine Barrett. And essentially, the framework is simply just ask every patient that you see, and instead of assuming that you know the answer. But how you do it is also equally important. What we heard from our patient advocates that you saw earlier was that they were really put off when a clinician comes into the room and does a sales pitch about clinical trials. And they become suspicious about why this person is pushing a clinical trial on them. Instead, what the modules, Just Ask modules advise is that we start with open-ended questions and get to know the patient first, exactly what you said, Matthew. So we start by what do they think about a clinical trial and how would they feel about participating in a trial? What would they need to participate? What's important to them, and what might they be interested in if they participated in a trial, as well as what challenges they might experience. And the whole training is based on a very easy to digest for clinicians case-based format. We're used to seeing cases all day, and so here's an example of a case of a woman who presents, and she's eligible for a clinical trial, and it asks for what are the reasons you wouldn't. And so that begins to point out, well, what are the reasons you might not, and what are those biases rooted in? So we published the pilot study findings, and here are the characteristics of the 49 of the 50 states that participated, which comprised almost 130 individuals. You can see there's a spread of academic and hospital and independent practices, and then the makeup of the teams that participated. And what we found was that when we looked at the mean pre-training in blue, the mean post-training, immediately post-training, and then at 6 weeks in the teal, what we found was an increase in knowledge about key concepts regarding implicit bias, including some of the reasons and factors that result in lack of diversity in clinical trials, the difference between equality and equity, the causes of health disparities, and how power dynamics shape those conversations about trials. And then, importantly, we also saw similar increases that were sustained at 6 weeks for key strategies and actions that we can all take to address the lack of diversity in trials and to build rapport and to engage underrepresented groups and to work across differences and work across both socioeconomic class differences as well. So the key takeaways from all this work was that yes, unconscious bias is real and it manifests through the assumptions that we make. It's the stories we tell ourselves about our patients before we ask our patients about their story. And that the assumptions do lead to not offering trials to all patients. And if patients are asked, just over half consent to participate. And underrepresented minority patients are not less likely to agree to participate. And that Just Ask training provides a simple framework to offer trials systematically to all patients and help mitigate bias. And that the preliminary data that I showed you shows that the training was feasible and that it had high utility and high satisfaction. So that's Just Ask. Moving on to the site self-assessment, this is also published. And what this site self-assessment did was to try to use our groups and the participating sites to develop better understanding of the programs, the policies, and the procedures that mitigate disparities in clinical trials, and then to identify evidence-based strategies to overcome those root causes of disparities in trials. And so here's what the pilot study looked like. It had two parts. The first part, we asked each of the sites to be able to report back or to report to themselves the number and proportion of patients that were screened for trials, as well as their demographics, the number and proportion and demographics of those patients that received the offer of a trial, and then subsequently the number, proportion, and demographics that participated in trials. And invariably what we saw was a decrease along that continuum, where at the left, people reported numbers that were more diverse than what ended up being the participants on the right. And so that provided them with insight as to where the major leaks in diversity were. And using some of their information, we developed these 7 domains for helping identify where those leaks could be and what best practices we could help advise. And you can see there were best practices related to patient access to the site, about mission and leadership, about the portfolio and availability of trials, and about their strategies for screening all patients, which oftentimes were missing. And then what best practices we could help them identify for supporting patient participation and supporting retention. So those are the 7 domains of the research site self-assessment. And here again are the participants. You saw these for Just Ask. These are for the research site self-assessment. And I won't read them to you, but you can see that it was a geographically diverse sample and as well as type of practice. And what we found here was that individual sites, once they completed the site self-assessment, had a pretty high degree of satisfaction with the assessment, and they felt it was worth the time and effort to help them understand where those leaks were to diversity in clinical trials, and that they were likely to use this when publicly available and likely to recommend it to other sites. In addition, you can see here their satisfaction with the assessment, and about 82% said they gained new insights about their own performance. 82% said they identified improvements needed by their site, and 74% felt that this had the potential to increase diversity in clinical trials. Most sites, one of the biggest learnings for us, however, was that most sites were unable to provide all the requested data across that continuum that you saw from screening to offer to enrollment and retention on trials. And so one of the important things that we did was to do a sub-study, and I'll show you the results of that, which is in this table. We then asked the sites if they could participate in this sub-study where they could tell us the proportion of patients they had in 2019 and 2020, where they had the demographics across the continuum from the initial screen to eligibility screen to confirmation of eligibility to offering on-site trials to offering off-site trials, and then the proportion of patients consented. And so the proportion of sites that reported they had demographic data, as you can see in the first column, across each of those points in the continuum was suboptimal. And we need to improve this so that we can help identify where we have the biggest ability to make a potential impact. And then you can see the proportion of sites that routinely collected the data in the last column. So overall, only 2 sites actually were able to give us all of the requested data. And when they did so, they provided it inconsistently, collected it inconsistently. So future directions, what we did was we developed a more streamlined version because the initial version was showing us that much of the data wasn't even available. So we developed a version 2.0 of the site self-assessment, and it still has the same 7 domains. And what we're hoping to in future directions is to actually understand not just the site experience, which is what we did through this initiative, but we're going to move into a new ASCO Research Learning Collaborative. And now this was just announced earlier this year, and requests for applications went out nationally, and ASCO chose the initial 15 teams that will actually use the site self-assessment to collect the data, to gain insights about where they could improve. But then what ASCO will ask them to do is to identify quality improvement practices that will increase the enrollment of underrepresented minorities in trials, and then collect that data, which we didn't do before. We didn't have pre and post data. We only had their experience data. So what these 15 inaugural teams will do is that they'll participate in ASCO's quality training program as a way to support their quality improvement plans. And then they'll participate in this opportunity to share the learnings with one another through this learning collaborative. Subsequently, ASCO will identify what were those quality improvement strategies that actually led to practice changes, and so collect that evidence to be able to share with other sites. And then the teams are expected to submit their abstracts and publications to the 2026 ASCO Quality Initiative. UPenn submitted one application, and so we were chosen to participate, and I'm really excited to have our first meeting, which will be next week. The last slide that I'll have for you is just to tell you that while all of that was also happening, ASCO does have a clinical trials access and inclusion task force that was brought together in 2024 for a year. And their task was to conduct a landscape analysis of all the resources that are available to increase underrepresented minority participation in trials and identify where the gaps are and where the opportunities are. And then to convene these stakeholders from around the country in this task force and develop and draft recommendations, present them to the board of directors, and then subsequently incorporate them in a strategic plan. I saw the draft recommendations since I'm part of this group as well, and they encompass 4 big items which have to do with clinical trial design, the decentralization of trials, the opportunities in community outreach and engagement, and then lots of clinical trial innovation, some of which I've been hearing about in this conference as well. So those recommendations have not been approved by the board, so I'm not able to share those with you, but please know that those are coming, and they'll have additional opportunities for all of us to make impact on the participation of diverse patients in trials. So with that, I will end. We'll have questions and answer in a bit, and I just want to say thank you to the enormous teams that participated in all of this work, including my friend Karen Wingfield, who's here. With that, I'll say thank you for the opportunity.